Well, hello, I'm thrilled to be here. I'm with the International Diabetes Federation, and we created diabetic foot guidelines in 2017 on preventing diabetic foot ulcers and amputations. They are still the most concise, the easiest to read, and the best and very well understood guidelines. They're about to be relaunched on the website, but they still are available. You can search them under diabetic foot guidelines and the pocket chart. Now, why is this important? Because we do not have enough healthcare practitioners globally that fully understand the progression of diabetic foot disease, from freshly diagnosed with diabetes to insensate with neuropathy to limited joint mobility to fungally infected with onychomycosis, and then down to ulcers and infections, and then the Charcot foot, and then the amputation and death. And because we do not have enough practitioners that understand that deleterious pathway, we don't have enough practitioners that can prevent this from happening. So that's what we're going to talk about today. So I'm a podorthist. I'm a US and a Canadian podorthist. I practice in Canada on Vancouver Island. I am trained in lower extremity amputation prevention and certified management and treatment of the neuropathic foot. I was lucky enough to be appointed in 2016 to the Diabetic Foot Stream Committee of the International Diabetes Federation, and that's where we created the diabetic foot guidelines that were put on in 2017, the guidelines and the pocket chart. I urge you all to go onto the website and take a look at those. So the diabetic foot, we have a huge problem because we need to treat this as a disease entity in its own right. Keep these patients protected, keep them on the ground, walking and mobile so they can fight their increased glucose so that they don't get neuropathy, so that they don't go through this pathway and this cycle that will take them down to ulcers and amputations. So right now, we have 583 million diabetic patients. So it's between 9 and 11% of the population. Now, in the next 24 years, by 2050, that number is going to swell to somewhere between 853 million and 1.3 billion was the latest stats from the Lancet journal in 2023. So that's almost going to double. Usually with these guidelines, it's the highest number. That's where we usually end up. So the cost right now with diabetes is $1 trillion a year. That is 1 million. That's a huge amount. That's 12% of the global health expenditures. What are we going to do when those numbers double? Like, it's unsustainable unless we get ahead of this disease. So diabetic peripheral neuropathy, that is the key to the destruction of the diabetic foot. The high glucose above A1C, the glycated hemoglobin of 7% damages the endothelial lining in the blood vessels, and that kills off the nerves. Now we don't have nourishment to the nerves, and now there's no nerves to innervate the blood vessels. There's an intertwine between the two. We need them both healthy. So without this, we get nerve damage. We get neuropathy. We're literally killing off the nerves. And now it affects all three types of nerves: motor, autonomic, and sensory. So why is the neuropathic foot different? And it is different, and by different, I mean vulnerable to complications. So it affects the motor nerves, so it denervates the small motor nerves, and now there's an imbalance between the muscles, the extensors on the top, and the flexors below, and we start to get clawing of the lesser digits. We get exposed metatarsal heads. We've got a lot of pressure on the tips of the toes. We've got a lot of pressure on the metatarsal head and the heel. And those are areas where we're going to have peak pressures where ulcers are going to open up. The neuropathy also affects autonomic, and so this affects the sweat glands and the oils, and you get skin that's less flexible, less pliable, more open to stress in the skin, more open to ulceration. And of course, it affects the neuropathy, the sensory nerves. So we lose protective sensation in the foot, and now the patient cannot get feedback to their brain about when they should rest, get off their feet, change their footwear. We lose the protection when we get sensory neuropathy. And we know that 70% of these diabetic patients will eventually lose some protective sensation in the feet. So that's a huge number coming down the pipeline. We know that up to 25% of those with diabetes will develop a foot ulcer. Now, these aren't just little red sores. These are big, fat, red markers that this patient has a 5-year mortality, a 55% 5-year mortality rate. That means 55% will not be alive in 5 years. So what can we do about that? Well, these are the guidelines. So they're on the IDF website up in the top right. You search diabetic foot guidelines and pocket chart. These guidelines are 70 pages, very easy to understand, broken down into 6 sections. It's the introduction, diabetic peripheral neuropathy, peripheral vascular disease, ulcers, infection, and the most dreaded consequence is Charcot-neuroosteoarthropathy. We want to protect these feet well before we get to that. So I was one of the authors on these guidelines, as well as the rest of my esteemed colleagues from many countries, Dominican Republic, Korea, China, Mexico, the US, and of course 2 here from India. Dr. Sherrod Penzi and also the late Dr. Sadako. He was our wonderful IDF president in 2016 and 2017 and a great contributor to these guidelines. So let's talk about the pocket chart. So the pocket chart is this one page. You can print it off. On the front is the risk categories. On the back is the diabetic foot exam. Now let's talk about risk category 0. We check the patient for neuropathy, 1 area on the top of the foot, 9 areas on the bottom of the foot. If they can feel all those 10 areas, they're a low risk. They're a risk category 0. They just have to manage their blood sugars below 7, and they get checked in 1 year. If they have some neuropathy, if they can't feel even one of those areas, then they get pushed into risk category 1, which is moderate risk. At this point, they need offloading with orthotics. Orthotics to spread the weight across the whole foot and to cushion those structural foot deformities. Now, what will push them into risk category 2? This is high risk. This is either they, as well as the neuropathy, they also have a structural foot deformity, limited joint mobility, or a problem with blood flow, and or they're infected with onychomycosis. So fungus will also push them into risk category 2. What they need there is custom foot orthotics, again, to spread the weight across the whole foot and decrease the pressure on the high peak pressure areas. They might need diabetic shoes, and then they'll need some foot care nursing to deal with the fungus. And we really want to treat heavily in the risk category 1 and 2. That's where we want all of our resources. That is the window of presentation. We want to focus our resources there, treat them aggressively, and they can live very happily in risk category 1 and 2. What we don't want them to do is go into risk category 3. That is very difficult to deal with. That is an ulcer, an amputation, or a Charcot foot, or a history of an ulcer, amputation, or a Charcot foot. Once the wound is open, it's very difficult to deal with. They're walking on these wounds. It's 80% of our resources and our costs are going into risk category 3. So I can't stress enough that we want to treat early in this window of presentation. There's a summation of the 4 risk categories. We are urging all healthcare practitioners to treat early in that in that window of presentation, risk category 1 and 2, and before an ulcer opens up. And that's really the goal of the guidelines. Early intervention in risk category 1 and 2 to prevent the patients from getting to 3, which is ulcerations, amputations, and literally death. The second goal is mobility. Keep these patients on the ground, walking and mobile, so they can manage their blood sugars, so their blood sugars don't get elevated, so they don't go through this pathway and get neuropathy and then go and get these complications. So this is the back of the pocket chart. This is the diabetic foot exam. It focuses on motor neuropathy, sensory neuropathy, range of motion, structural deformities, skin integrity, nail integrity, and offloading. So again, that is the back of the pocket chart. Very easy and accessible, and these are still the very best guidelines that we have. So what do we mean by offloading? So if you take your finger and you poke it into your thigh, that hurts, right? That is the peak pressure of your body weight coming down into the tips of the toes, the metatarsal head, or the heels. That's where you're going to get an ulcer. So now take your hand, press it into your thigh. That doesn't hurt because we spread the body weight across the whole foot and we decrease the peak pressures coming down. And now we can't get an ulcer. And we use diabetic orthotics that are cushioning. They've got a plastizote top so that it cushions around the structural deformities. And it's also, the pink plastizote allows us to see blood in case a wound opens up. So what's the consequences of missing risk category 1 and 2 and the patients falling into risk category 3? Well, we know 25% of these patients will develop a foot ulcer in their lifetime. We know that there is a 55% 5-year mortality rate. So 55% will not be alive in 5 years. We know that 1 in 5 foot ulcers will lead to a lower extremity amputation. And we also know that 68% of those with diabetes-related amputations will be dead within 5 years. So there is a 68% 5-year mortality with diabetic amputations. We know that there is upwards of 5 million deaths per year with diabetes and its complication. So the call from the IDF is simply get the practitioners on the ground treating this at the very basic level. Treat them urgently in risk category 1 and 2. Treat them in that window of presentation. Offload them, treat them with foot care nursing, and treat them earlier. And ultimately, we also want to prevent new cases. Again, this is the risk category chart, very easy to understand. This is the bread and butter for all practitioners in all countries. So we know we have a huge pandemic of diabetes in every country in the world. We know that it's a super large global health challenge. The way to get ahead of this is treat diabetic foot disease as a disease entity in its own right, and get the guidelines and the pocket chart off of the IDF website. And I hope you all enjoyed this presentation. Thank you for having me.